Hi, people. Welcome to the NMS Health Talks podcast, a show where we discuss NMS operations and the broader health sector. For the very first time on the podcast, we are hosting someone who is not a staff of National Medical Stores. Yes, we are hosting the District Health Officer of Bundibugyo District. Good doctor, please tell the viewers about yourself.
I'm Chita Christopher, the District Health Officer, Bundibugyo Government, and my role is to oversee the provision of the health services in the district, and also oversee the implementation of related policies in the district. So that's generally, I can summarize it like that.
So your role is mostly about the health.
Yes. How
long have you been a DHO in Bundibugyo?
I've been DHO since 2017. The first 3 years I was acting, and 2019 that's when I was confirmed. But overall, the mantle started from 2017. Yes, up to date.
Okay. So we have had so many good things about you. There is this particular initiative, the District Medicines Management Team, that you're implementing very well in Bundibugyo District. And we are interested in learning more about it. So first of all, what is DMMT?
DMMT is a District Medicine Management Team. And this team was brought on board. Actually, it is just an idea. We just crafted an idea that there's a lot of things going on, and currently there's a lot of interest in the availability of medicines, because the community is primed to think that the availability of medicines is the cure for everything. So we looked at the gaps in the system in our district, and also the possible causes of stockouts, the issues people could keep on complaining about, the quality of care. Some of them may say they don't receive what has been prescribed, and also complaints that the medicines don't stay for long. So wanted now to understand deeper what is going on. But above all, we looked at accountability for what is supplied. So when you compare the funds, primary health care funds sent to our facilities, and then the allocation of medicine under quality line, realize that the total medicines taking 50%, more than 50% actually, depending on the different levels of the total allocation. That is when you add the allocation under medicine plus primary health care, that is minus when we reduce the results-based financing, because that money keeps on fluctuating, it depends on so much on performance. But now when you look at the many primary health care, which is being decided on as per allocation, and then the medicine, you find that the medicine is taking more than 50% at all levels. But yet, when we look at the emphasis on accountability, you have not had the practical things which, or sometimes you have undermined some small things which can be done the way they have done for primary health care funds. For example, in a PHC fund, for PHC funds, was FN charges are supposed to display what they have received. Whereas for medicine, we're not treating it as like that. So now somebody would say NMS has not delivered, yet the medicine are delivered, because it has been made. We looked at it as maybe an scapegoat. People don't want to take problems. If there is a stock out, they will say, we have not had the deliveries. Or they will say, the last delivery was done 3 months ago, yet it was 1 month ago. So now we are moving to practical ways, or some simple ways which are not even more costly than others. Simple interventions to improve accountability for the medicine supplied, and also we are looking at rational use of medicines. Because you may find that somebody comes with malaria, but diagnosis is malaria clear, simple malaria, uncomplicated malaria. And now is given, for example, whatever, given paracetamol, which commonly people call Panadol, and they add the antibiotics. You may find they have added amoxicillin or another one. And then also, I find they also have another one. So somebody goes with 4 tablets. And that is a high pill burden already. So malaria is there, other things which are not even there are catered for. At the end of the day, such practices, they expose the system of stockouts. We are consuming what we are not supposed to consume. And then when the right person to consume what you have taken has come, we will not find the drug. And so another may be something which of interest, which we realize is that now when you look at what poor consume of the drugs are the patients. The more the patients, the higher the volume consumed. But now when we are moving that state, there's no guarantee that even if you multiply or you double the supply, there's no guarantee that it will ever be enough. So in addition to that, we thought that it may be the same team and take on the mantle of promoting FA promotion and the prevention strategies. When we dissected, you can use the word dissected, when we internalized and analyzed and here and there, whereas that we needed when you look at other programs, for example, we have MPDSR, that is the maternal and perinatal deficit review committees at a district level and even at a facility level. We have quality improvement committees even at district level. So now when you look at the medicines, which even take a big part of the budget in the health sector, there was no effective leadership, governance and management role. It was not there. That gap was. So we find that health center, hospital and force, they have medicine therapeutic committees. Now ministry, there is a summer committee. The district, there is nothing. And yet now this is where we focus. So overall, we looked at the goal of that this committee will provide the strategic management, leadership and governance in order to promote, to improve health outcomes and also improve the availability of medicines. And now the key objectives which we came up with under the purpose of this formation, one was to improve on availability. The second one, actually there are four, mainly there are four. First one is improve availability of medicines. The second is to promote accountability for the medicine and the health supplies. The third one is building capacity of the health workers involved in dispensing or who interact with patients and in the day-to-day life of the patients, the interface with medical prescription, dispensing and others, including the stewardship areas. Now the fourth was more coordination with other stakeholders. Because you find, for example, somebody would claim NMS has supplied delays. Yet what has been supplied has just been stolen. So now that coordination arm, that if there is a complaint, where do I run improve first to get clear facts? Should I also join a bandwagon and say declare that yes, true, MS is like that? Should I say maybe I join the bandwagon and say we have not provided documented security for our what we are supplying? So that's one of the things. And also there are other stakeholders, the community. How to coordinate with them. When they raise concerns, do we give a feedback? Or we also keep quiet and join them? When you keep quiet, then you are building something even more severe. Okay, so like you're piling dry grass and you're going to put it on fire, and you may not have that adequate capacity even to quench the fire. So those are mainly four of objectives under the purpose and of the formation of the district medicine management team. Now this team idea it has not even celebrated this first year. Yes. The idea came towards the end of the financial year. That's financial 2023-2024. That's when the idea came up. And how it came, we have been doing a lot in medicine management. And we have even people responsible. The DHO has a role. The district medicine management supervisor, the DMMS has a role. We have those ones that have sub-districts. And then also we have assistant inventory management officer for the DHO's office. Even we have the district audit chain technician. We have a biostat. We have internal audit. And most of these people they are dealing with it. But now when you look at the way we are acting, we are more in two solitary stakes. We find the DHO is approving alone. The DMMS is one supervise our own devices report center in the system. Even the other sub-district. So we found that now how do we create one team and then which can communicate to each other? So that is how the idea came in. So now that is when that's by July we had our first induction. Where I saw the idea before even informing going to put a cow. We had the I went into internal audit. We started with our team also. And that time the cows we picked the one in charge of health. And we first discussed. And from discussion they said that is feasible. The only issue, one thing which was needed was exchanging skills and knowledge and skills. So that's how. So we have not again. So now we are consolidating all the actions, put them together into a plan. So it's more like getting more organized than before when we are tackling issues with medicines. That is the idea. So which means the first activity, doing activity was done in September. That's the first major activity. It was among the activities that was the major activity, and is actually the most complicated activity we ever done. And the first time we did it, it created the fruits, very obvious fruits. And then we looked at it as an high impact because we have so many interventions. But that one immediately we just categorize it as high impact. Then as we are going to implement others, because the others also we are going to bring some of them are at the departmental level like audits.
Could you tell us what achievements DMMT implementation has registered in Bundibugyo since you started in September?
Yes, now the first success is because now we are looking at availability, accessibility, traceability, accountability, promoting health promotion and disease prevention. So in all those areas we have achieved. And probably what we have added on is the understanding our malaria prevalence. It's not like the figures are not like what we was on the ground. So what was on the ground was higher compared to what the actual would be.
What was on the ground, or what?
The cases, when you look at the cases registered for malaria, vis-a-vis, because you are looking at the HIS2, HIMS, and then the registers. All of them were supposed to communicate the same language, including also the consumption for commodities. And one of our key commodity of interest was the antimalarials, like the non-recalcitrant antimalarial, the HIV, the HIV testing this were there, malaria, bits, and then but we found that the consumption of medicines was higher compared to the number of cases on the ground. So, and also we found that some cases were not actually true cases of malaria. We find the lab result is for negative, but in the register, you see cases there. So we now lowered our numbers. Just like that. So now the another thing is the availability. Now we used to have stockouts of antimalarials and some other vital medicines. Now as I'm talking now, okay, we have spent more than 6 months. Actually, from that September, when you look at from September, the time we did that activity, we not had any reported this stockout of antimalarial from any facility. and yet we look at the cases have even reduced. The medicines are more available. Actually, we have more stock even to redistribute. Then the accountability reporting has also improved. The quality, because you are looking at the accuracy. Are they reporting the actual balances, because they have to account for the balances, or account for medicine utilized and the balances. Yes. So you find that the time you could find that what they are reporting is either lower or higher, because we are just putting in the figures. Now that one has improved. Then also the completeness of the reporting, because there are items under those sections in HIMS which have to be filled. So now you find that you could do some areas not filled.
So what is HMIS?
That's the FM Management Information System.
Health Management Information System.
The tool is a tool to capture data, and that data is entered into a district FM information system, which you call the DHIS tool. So now if you look at also one other thing is equity, because now we find that under our system, when there is a minimum stock levels, you report, and we bill you before you actually reach a stock out. So that one I have done, and it has helped. Now maybe before I forget, one of the key things which you have achieved under this arrangement is the reduced referrals from what is the center which was fond of referring patients because of lack of commodities. But now the referrals due to, especially for operating theater, cesarean section mainly. So you find that the referrals due to cesarean section were reduced to 100%. So they cannot give a reason that the referral is because item A is missing. So that is the section is going to be done from our facility because of logistics here. That one we have managed that.
Wow. And DMMT is doing wonders and miracles in Bundibugyo.
And it will just within a short time.
Yes. So is this DMMT only unique to Bundibugyo or throughout the whole Uganda?
I will not lie to you. I will not done so much to inquire from colleagues. But the last time when we were trying to come up with it and try to look for information here and there, we failed to get any place which has this formation. So I cannot categorically say that we are the only one, but I am confident ours is there.
And this is working.
It is working.
Okay, so how does National Medical Stores support the implementation of DMMT in Bundibugyo, to be specific?
This is supportive. The first support is giving us a feedback. And where we are in NMS, because of that feedback alone is a support to us. Because the body came, they explained what we are doing, and they picked interest, and we added to. But that is still, that's one of the, because under our stakeholder analysis, there is an element of information sharing, coordination, and others. So now another issue is that and as which NMS has contributed, because we are looking at information. Now, the NMS, the documents related to deliveries are in place. We will always find them. Any information we need, some of it is electronic. You can always available. And when you need it, and any time. So that is still the information availability of very necessary information. For example, the delivery notes, they're in order and signed and they're available. Then what also during the recent procurement, where we invited for next financial year.
Procurement planning?
Yeah, procurement planning, where we invited the in-charges from different facilities. NMS was facilitating and guiding our teams on appropriate procurement using the data. So that is a big support, because our interest is we need to manage availability, we need to do right ordering, you need to do right quantification, and for value for money. You want to order for something outside which is not a priority, a disease, you order for, and it's costing even. So that one we did a big role through our regional office. We have been coordinating in that line and streamlining things and appropriate ordering. So I think, and there's so many things. If I am to describe how we are has contributed, it is a bit wide. Now maybe before you forget, and when they were distributing, we are given this new clinical guidelines. So that is and the ones which we are even using during the training. So that is a facilitator. Positive participate under NMS. That facilitates our work because when people have the guidelines in place, and now for us now we go and say, okay, we are assessing rational use of medicines. Do you have the guidelines? If it is available, then if it's available, yes, that is a tick. Then now we go deep into assessing, is it being used? So that is what I can comment about.
Okay, so from your presentation, I have deduced that you're saying drug stockouts are not there because NMS is not delivering or not delivering in time, but the mismanagement of medicines.
Yeah,
the lack of accountability.
Yes, that is true, but maybe the best way to describe it is that we have been having avoidable and what I can call avoidable preventable stockouts. Whether NMS has delivered or not, but we have had stockouts which wouldn't have got if things were moving right. And then we need to say stockout which is supposed to be there. And then we say it's supposed to be there, but this is not the artificial. Of course, artificial stock-out, caused, induced stock-out, and within our sector players.
See. So artificial stockouts are what?
Now, just reports you will
For the benefit of the audience
interests.
there.
Like I am the any charge, you still drugs. That is it. Inducing what?
And then a stockout.
And which is if you don't steal, you medicine and be available. So now if you steal, you are now denying access. Then there is where the medicines are available, but people are lazy to go and people in from the store. And that thing has happened a lot.
That is the thing.
So the medicines are available, but access.
But they are refusing to pick it from the store.
Or it was out of stock last week. Now for distribution, we go to the medicines, but now people continue to tell people that it's out of stock. So you just say that is preventable, that's avoidable, that is induced stock out, which is not there. So I've called it artificial, like induced. There's nobody who say that artificial, but I'm just saying somebody is just trying to bring something which is not supposed to even be there.
So in your opinion, what are the biggest challenges to medicine availability in Bundibugyo?
Now the biggest challenge is the disease burden. That is the biggest. Because whereas even when we do analysis, 8%, 8 out of 10 diseases are prevented. And even those ones which we cannot prevent, for example, the hypertension, that is high blood pressure, diabetes, there are strategies which you can put in place to delay the occurrence of such conditions by your appropriate interventions at an individual level. So that is one of the biggest factor. Now the other factor, one of the challenges we faced when we are day to day dealing with medicines is either to say unaccounted for, what was the story. If you are going to this other part, they will say if it's stolen, do you have evidence of theft? Then unaccounted for. So now unaccounted for can be maybe it was stolen, or maybe there was poor record management, which also we are addressing. So it can be in different forms. But now we like all of them combined as mismanagement, or poor inventory management, or even poor logistic management. All of them can contribute to that. But the other than the main thing, disease burden has to reduce. The issue of inventory management is a key issue. Then logistics, we are sorting that logistic. I think that is even the last at the moment. The logistic management, but if so, those are the key challenges which we may need, and even poor accountability. You find even a facility where you know that you can steal, but you have not accounted.
But you know they haven't stolen.
But yeah, we know them because we do red flags and we are assessment, high risk, low risk, and yeah.
Thank you so much, Doctor, for this enlightening conversation. You have provided valuable insight in how the health sector is working towards increasing medicine availability, not only in Bundibugyo, I'm hoping also in the whole of Uganda. Yeah, so thank you for sharing your story with us. It was a pleasure hosting you on the NMS Health Talks podcast. For the viewers, if there is any topic that or issues that you would like us to discuss on this podcast, please let us know in the comments section. If you found this conversation as enlightening as I did, don't forget to subscribe so you don't miss out on more. Hit the like button and see you in the next episode. Ciao.